So, good afternoon, everybody. Welcome to our webinar series on laparoscopic colorectal surgery. And as you see, we have a webinar series with 8 modules on colon and another 4 on rectum. And actually, we are already in module 10. So if you missed some of the modules before, you can look them up on the webinar series, which is on YouTube. So now I will come to our distinguished panel from today, and we see that this will be orange all over. 3 good friends from the Netherlands. I really worked very long with them. You know, the modules are built up by Colin and me mainly, but also Andreas Chamier from Austria is one of our boards. And we always pick up some guests who are very experienced in the fields also. And I want to introduce Jurian Twinman and also Roel Hams. They are both now in Amsterdam, very, very famous and really good friends already and have experience. And that's why we put them in today. So thanks a lot for the moment. And I hand over to Colin Sieges, who is one of our board members. And he's also from the Netherlands. And he's talking first about the literature of transanal minimally invasive surgery.
So we started the presentations, the 3 presentations, with a couple of questions to see, to get an idea what your knowledge is about local excision and to see where we should focus. So the first question is, what is the best diagnostics for an adenoma of 2 centimeters at 5 centimeters of the dentate line, Paris LS and Hiroshima C1? And if the biopsies come back from pathology, it shows an adenocarcinoma, which is well differentiated. So what would you do? A local excision as diagnostics, an MRI, and a local excision, endorectal ultrasound, and a diagnostic excision, or would you go to TAMIS surgery immediately? So keep this in mind. A lot of you do diagnostic excision or MRI and diagnostic excision. So maybe at the end we come back at these answers. Second question, 50-year-old patient with a mid-rectal lesion of about 2 centimeters, biopsies showing an adenocarcinoma, and the MRI shows you it's a T2 and 0. What would you do? Would you do a local excision and completion surgery if needed? Would you just do a local excision? Would you do TME with anastomosis, or would you radiate and do a TME with anastomosis? What's your option? About half. Some of you would do local excision and completion surgery if needed, and some of you would go straight to TME surgery. Okay, next question. So same 50-year-old patient, but then female with an anterior lesion at 12 centimeters above the peritoneal fold, and biopsies showing adenocarcinoma, and the MRI can't discriminate between a T1 or a T2. So what would you do? A local excision or a PME? So majority of you would do PME. Thank you. And the last question, a 50-year-old patient, pathology after local excision shows you T1, 3 centimeters large, an SM2, no lymphatic invasion, and poorly differentiated. What would you do? Close surveillance, completion TME, chemoradiotherapy, or inclusion in the TSR trial? And if you don't know what the TSR trial is, don't worry, I'll tell you later on. So majority would do completion TME, and a really good, some of you already know the TSR trial, so that's good. So thank you for the answers. If we have time, we'll deal with them again at the end. But now I'm going to start with my lecture, and I'm going to focus on literature of TAMIS. So what will I do? I will briefly discuss the history of transanal excision, which techniques are preferred, open versus endoscopic, TAM versus TAMIS, and then I will go a little bit more into detail about the evidence for local excision for early rectal cancer, which diagnostics, but I'm sure that Roel and Jurian will also go into detail with this. So transanal excision, historically, there's actually only one technique which was used, and that's the open transanal excision, the Parks method. And it was generally considered a relatively easy procedure. But if you look into the results in more detail, then you can't really consider it an easy procedure because the recurrence rates were up to 60% back then. But it was the only technique which was available. And it was the only technique available until Bues reported his transanal endoscopic microsurgery. And he reported a technique with a recurrence rate of lower than 4%, with a really low morbidity as well. TAM had some advantages. It had really good stereo optics, and one of the big advantages of TAM was that special insufflator, which gave a really stable pneumorectum, but it also had some disadvantages. It's a relatively difficult technique to learn, and it's quite expensive. So the not that many certain hospitals were able to do the TAM surgery. Eelco de Graaf is a Dutch surgeon who was one of the pioneers in the TAM field, and he did a lot of research in the beginning years of TAM. And what he did a comparative study of the TAM versus the open transanal excision. And what he saw is that TAM was superior in percentage of negative margins. But what he also showed is that the polyps were removed with TAM in one piece the majority of the times. And when you do it open, the polyps were fragmented quite often. And if you look at the results of polyps which were fragmented, you can see that the recurrence rates are significantly higher when the polyp is removed in more than one pieces. So that's really important if you do it endoscopically. Overall, the recurrence rate were a little bit better than reported in literature before, but still open excision had a recurrence rate of about 70% compared to TAM, which was significantly higher. The same authors also reported that with TAM, polyps could be removed from the complete length of the rectum, so even higher up than 50 centimeters it was possible, and opening the peritoneum wasn't any problem. As long as you recognized it and closed it, it didn't have any impact on the morbidity. So TAM was actually the only existing technique until around 2010. And then Sam Attell published a new technique. And this was about the time that a lot of surgeons were experimenting with single port surgery. And there were also some couple of groups which were starting to use the single port systems for transanal use. And Attell and the group showed that it was safe to use this single port surgeon to do local excisions. And they also named it transanal minimally invasive surgery. But if we're honest, the beginning years were quite a struggle because the single port systems which were there weren't meant to use transanally, and more importantly, the insufflators weren't built for transanal use. So we had a lot of problems with smoke, and the operative fields were bellowing a lot. So the rectum wall was moving around. So it was a little bit like a rodeo surgery, and it was often quite difficult. Fortunately, currently there are a lot of new instruments. There are new platforms like the gel point path, and also next year there are some new trocars coming from AFS Medical. More importantly, the insufflators, they have improved significantly. We have the AirSeal insufflator, which gives us a really stable pneumorectum, and currently the Lexion insufflator, which is, in my opinion, superior to the AirSeal because it doesn't have any air leakage, specifically in COVID times. That's really important. And a cheaper version is the insufflation bag of Applied, which is really helpful as well. So the same group of Sam Attell also did a comparative study with TAM, and they showed that it's safe as TAM, and you can have the same results if you're skilled enough in both techniques. So which technique should be preferred, TAMIS or TAM? Well, personally, I think TAM is easier, cheaper, gives you more freedom of movement. Big advantage is that you can put all your patients in the lithotomy position. But if you have TAM and your surgical team is familiar with the TAM instruments, there's absolutely no reason not to use the TAM instruments. The learning curve, same group again of Attell, showed that it's approximately 20 cases to learn a local excision transanally, and there are a lot of workshops where you can learn it, so you can be proctored by it. So this is an acceptable learning curve. So this should be accessible for a large part of the surgical community. So the next part of my lecture is the evidence for local excision in early rectal cancer. This is a slide I borrowed from Chris Cunningham from Oxford, and what it shows is relatively old data, but it shows that stage 1 tumors have a really, really good prognosis, irrelative what you're doing for operation. And in that time when these results were published, the main operation was still radical surgery. So you had to do a large operation for a relatively small tumor. And we should always remember that these large operations have a lot of morbidity, a really high stoma rate, and a lot of major morbidity. So the question is there a room for a local excision? And this all, of course, depends on the staging of the tumor in advance. So we should know what stage the polyp or the tumor is. And these are the classifications you all know, the NICE classification and the Hiroshima classification. They discriminate between normal polyps or benign polyps and polyps with a little bit increased risk of malignant transformation. We have the Paris classification, which looks at the size and the shape and whether or not there's a depression centrally, and the combination of them all is the LASSO classification, which looks at the Hiroshima classification, whether or not the polyp bleeds and whether or not there's a depressed area, and you can make a judgment what the risk of malignant transformation is. But it's really, really difficult to get a really good risk assessment. In the Netherlands, we did the TRANS study, which was a comparative study of transanal endoscopic microsurgery versus EMR for the treatment of large benign adenomas. And what they showed is that in 15%, unexpected cancer was found after endoscopic removal. So it's really difficult to judge which polyp is benign and which polyp is malignant. Do we have different modalities to assess the risk? Of course, we have the MRI, which is essential if you have a malignancy to exclude lymph nodes involvement, but it's really difficult to prove, to discriminate between a T1, SM1 till 3 or a T2. There may be some groups like the Gina Brown group who are really trained and can make a proper assessment, but the majority have a really low, a discrimination rate. The other modality is the endorectal ultrasound, which has really high expectations, but to be honest, it's not really proven. It really, really depends on the expertise of the sonographer. If you have a really experienced sonographer, then it might be helpful, but in the Netherlands, there's not that much experience. And there are also some reports from the UK that if they compared the definite TAM pathology with the preoperative staging with endorectal ultrasound, then there wasn't that much accuracy. So how to differentiate between benign and early rectal cancer? The endoscopic image, the ultrasound, or the MRI image? Well, in my opinion, you should always do a full thickness diagnostic excision and look at pathology to get a proper diagnosis. So is there room for early rectal cancer in the treatment, is there room for local treatment in early rectal cancer? Well, to be honest, actually, if you know that the lymph nodes are negative, then any T stage can be treated with local excision. But that's, again, the problem, because you're not aware of the lymph node status. And the lymph node status varies extremely, from 3 to 25%, and it really depends on the size and the depth of the invasion, lymphatic invasion, differentiation grade, vascular invasion, whether or not there's tumor budding. And that really gives a really variant recurrence rate. And if we look at recurrence rates, most of us still use the results of the Bach study. And you can see that there is a certain subgroup of patients which has a really good prognosis after local excision. But if you look at all the patients together, the local recurrence rate is quite poor. The same results are there for the T1. If you put all the T1s together, local recurrence rate are relatively high, but the subset of patients does really well. This is the overview and the risk assessment, which is from the article of Bach. In the Netherlands, we're allowed to remove an early rectal cancer of 3 centimeter or smaller T1 SM1 with a local excision. So somewhere somebody has decided that a local recurrence rate of 5% is acceptable and anything above is not acceptable. Or we can discuss about this, but this is what the guidelines in the Netherlands are currently is. So which patient to consider for a local diagnostic excision? Of course, we have to look at the size. Any polyp larger than 3 centimeter, the local recurrence rate is increasing really rapidly. So maybe only the SM1 with a size of 3 to 4 centimeters acceptable, but the rest, the recurrence rate are really high. Morphology, of course, staging, we have to know whether or not there's lymphatic invasion, because any recurrence rate doubles if you have lymphatic invasion in your biopsies. And of course, the location is also really important. Completion TME, the risk of that, we already know from a little bit earlier study that if you have to do a completion TME after local excision, this will influence your results. So the patient will not always benefit from a local excision. In this study, there were more colostomies and the recurrence rates were higher after the completion TME than were after primary resection. So you should discuss this with your patients, what the risks are. This is a study of Rule from his Oxford time, and what he showed is that patients who had completion TME and a poor quality of surgery had a significantly worse prognosis when you compare it with good quality surgery. And what were the risk factors for poor quality TME surgery? Those are tumors which are lower in the rectum, on the anterior side, and after full thickness dissection. So if you have a polyp on the back side, a little bit higher up, of course, it's safe to do a local excision. But if it's in the anal canal or on the anterior side, you might have a problem with future completion TME. Should you discuss this with your patient? Should you keep this in the back of your mind? If you're going to do completion TME, maybe transanal TME is better, but I will leave this to Jurjen. He will go into more detail about this. So at the end, is there place for local treatment for early rectal cancer? I think there is, but it is shared decision making. It's not only positive or only negative, because there are also downsides in local excision, but of course there are also really big advantages. But you should keep in mind that there are also risks. Again, these are the data from the Dutch Cancer Registry, and what we see is that we're doing more local excisions in the more recent years. And these are also local excisions for T2 and even higher stages. And what this article showed, that in patients who had higher stages of tumors, not always completion TME is performed. And actually, it's only performed in 29% of the cases. So a lot of patients who should have had completion TME are treated with watchful waiting, and this might impact the results at the end. So my last slide, and I think Jurjen will also present this as well, but if you have a tumor which is a little bit higher in stage and might not qualify for a local excision primarily, always think of the TASAR trial. This randomizes completion TME with adjuvant chemoradiotherapy, and maybe this might be the future for these stages of cancer, but we have to wait for those trials. I'm going to skip the video because I think I'm a little bit behind time, and maybe at the end, if we have some time, I will show it, but Roel is going to show videos anyway as well. So thank you.
So we go ahead and move to Roel, and it's a pleasure to have you here. He's one of the most famous transanal TME surgeons also, and had a lot of publications and that. But now we will see Roel about how to perform it.
Thank you very much for the introduction. I think it was a lovely overview by Colin of the literature. I think he touched on the most important topics, and I will sort of focus on some of the technical aspects. And as Colin already sort of said, it's really important that we sort of know how to recognize these early rectal cancer, because this is, of course, where the focus lies. And what is important, I think, what we can achieve with TAMIS local excision, that for each lesion that is sort of suspicion of having invasion, that this is sort of done resected on block. So we don't want piecemeal resections. So only if there's no evidence of invasion, then I think a piecemeal resection can be done. But this is usually done by your endoscopist anyway. But we have to be aware that lots of evolving techniques by a gastroenterologist. So there's a clear overlap between what they are doing and what we are doing. And I think you really need to have a good working relationship with your gastroenterologist to choose the best technique for your patients. And what I will be discussing today is which plane, and as I mentioned, I won't be discussing that much partial thickness, but predominantly the planes that we can choose for deep submucosal invasion, and this can either be full thickness or an intermuscular dissection, as I think full thickness is not always indicated. This has already briefly been shown by Colin, and really important that we also have a feeling for this. So based on gross morphology and based on narrow band features, we can sort of predict whether or not there is a risk for an invasive cancer. And as mentioned, if there is any sign of invasion, that polyp needs to be taken off on block, and ideally, of course, R0. But other things are important. Of course, we have the finger, but sometimes even with the finger, we can miss things. And here I want to show, this is a lateral spreading tumor with a dominant nodule with some suspicious features. But the video here, which I borrowed from Chris Cunningham, is really to show that we need to look at the whole polyp. And what you might have missed with your finger is the smooth adenomatous tissue, which is reaching up to the puborectal sling. And even, as you can see here, is actually reaching into the anal canal. So here, if you put in your port, you're probably going to miss part of that adenomatous polyp, and that sort of will lead to recurrence. And the blue dye is there, of course, to get a complete good assessment. The video now on the left is there to show this is the water level, but the patient on his back. So this sort of tells you that this polyp is anterior located. And that was that interesting question that Colin said. If this is 12 centimeters anterior located, this might be a tumor where you're going to be ending up in the patient's abdomen, where there is a potential theoretical risk for spread. So what you need to decide whether or not you want to take this off by a full thickness excision. And of course, height, location, all very important when you do TAMIS procedures. So we'll now discuss with you how I would sort of set it up. And there are some residents in here, so I'll start with the first thing that we do is put in an anal block. And why do we give an anal block? Because it gives the patient good additional pain relief after the procedure, but will provide you with some extra sphincter relaxation. And with what I tend to do is a peranal block, so it's not a pudendal nerve block. So what I'm focusing here on is here the inferior rectal nerve, and this is the side branch of the pudendal nerve. And really important, it gives off branches to the external sphincter. And this is where the predominance of the local anesthetic, and we'll show a short video of it, is sort of put in. So I put it in at 3 and 9 o'clock, go through the skin, then outside the external sphincter, sort of towards the main branches of the inferior rectal nerve, and then put another sort of allotment 5 cc just outside the external sphincter where the terminal branches are coming in. This really works well. So usually 10 mils of Marcaine, 0.25 or 0.5%, depending on the weight of the patient on each side. So here you can see this is a female patient. So the patient is in lithotomy. You will have your screen sort of sitting over the chest of the patient so that you can sort of comfortably see that. And the tubing is usually either coming from the left or the right side over the leg out of the way. So here you can see going through the skin, then outside pointing towards posterior at 6 o'clock, putting in 10 cc's and then another 5 cc's when you draw back, and you repeat that on the other side. Then gentle dilatation of the sphincter, and I use a TAMIS platform, so I'll show this. What I'm showing you here is an insertion of a gel point part. So with a female patient, usually they have a shorter anal canal, and that ring here will sort of hook over the puborectal sling. It's a quite pliable platform, so you push it double. Don't put too much gel on it, because then it becomes too and then it sort of slides out of your hands. Some people put a clamp on the inside. I think usually it works really well. Push it in, and then sort of open up the internal side with your finger, or either with the blue dilator. And if the tumor is not going into the anal canal, I tend to fix the platform at 6 and 12 o'clock. Some surgeons do it at 3 and 9, but I prefer to do it at 6 and 12. But if of course, the tumor is extending into the anal canal, you can really pull this platform back into the anal canal and then start your dissection there. Or you have to do a hybrid approach, which I will also show you. In male patients, quick video of a male patient. Here, I tend to always use a lone star, because then you can evert the hemorrhoidal complexes a bit, because sometimes the platform is just not long enough, although applied has a longer platform. But to get it properly in, then I tend to, after the anal block, put in a lone star and then put in the TAMIS platform. And you know when the platform is in good position, when, if you look in, you see a circle, then you know it's sort of opened up completely, and you're sort of just above the puborectal sling. If the platform is too low, usually it's squashed by the pelvic floor, and then it's more difficult to do your procedure. So the port arrangements, and again, this is very surgeon specific, and I would advise you to do sort of a TAMIS workshop, because then on excellent models, you can get a good sense of what works for you. So I tend to put, if you have the triangle of the applied lower there with the cap at 1 o'clock, I tend to put my camera in on the patient's left-hand side, and then 2 working instruments on the right-hand side. And you can see I'm using an air seal insufflator. Colin already alluded to other insufflators, but this is where my working instruments are going in, and sort of working with my hands on top of each other. Why do I tend to do that? Work through these 2 ports is because that allows you lots of angulation to reach tumors either being situated anterior or posterior. If I've got a tumor located posterior, then my hook, because I usually work with a hook, comes from the top port, because then the angulation downwards is the best way forward. Of course, if the tumor is located anterior to the upper port, and I think by this setup, you get the best access to the anterior and posterior quadrant. So here again, I'll show it as in a short video. The port is in, and then the lip of that applied platform, I position that at 7 o'clock, but I sort of hold it already before me, as it was positioned on the access channel, and that's my camera position, and then the 2 walking ports on top of each other, and this is a very nice platform with a gel that sort of prevents the air leaking, although there have been some studies that you tend to get some air leaking through the gel and even through the ports, and here you can see the air seal being pushed in. And then this cap is sort of hooked on the access channel, and then you can start your procedure. So applied has what they call an insufflation stabilization bag. So you have then a special port where you have a large insufflator access, and then this bag is hooked up to your standard insufflator. But then you can get a stabilization of your pneumorectum, but there's no smoke evacuation. Then you have to use either a diathermy instrument with simultaneous suction. So they also provide then an Epix probe, which is sort of slightly angled, which then allows you to do the dissection and extract the smoke at the same time. As Con already mentioned, there's now lots of insufflators that are getting much better. So you've got the high pressure insufflator of Stryker, but really interesting because this is a closed circuit. the Lexion Intelligent Insufflator, which really works well. So now the techniques for the different type of planes. So if you have an adenoma with either high-grade dysplasia, or when you've got potential superficial invasion, then the submucosal plane should be enough in the majority of your cases. But again, it has to be on block. So full thickness isn't absolutely necessary here if you don't have deep invasion. I don't tend to do this a lot because, as mentioned, these polyps usually get taken off by our gastroenterology colleagues. But this is actually still a TEM video, but just to show you the planes. And what I tend to do also, if I do these submucosal dissections, then I tend to lift it as a gastroenterologist would do, as you can see here, and then always start at the distal aspect. And what the blue dye does, it allows you to visualize the muscular layers of the rectum much better. You see the blue dye, and everything white here is the muscle layer. And here you can see the circular layer of the rectal wall perfectly preserved. You can also then see much better the blood vessels, and I would advise you to take these all the way separately because these can bleed vigorously. But you can see in this submucosal plane, you can take off these lesions quite easily. It becomes a bit more tricky when you've got larger polyps, and this was a large spreading, a lateral spreading tumor with, again, a suspicion dominant nodule, but again, leading into the anal canal. So there it's difficult for our endoscopist colleagues, but also to start off primary with your platform in the anal canal. So here we start with a hybrid approach. So we start with an anoscope, again, lifting the planes, and you can see here the internal anal sphincter, the white layer, and this is your submucosal plane. So here we started off by dissecting that intraanal adenomatous tissue off, nearly fully circumferential. You can see we started here, and there's still a strip of approximately 1 centimeter left. And once we reach the pure rectal sling, we put in the TAMIS platform, then the proximal marking of our lesion, did a submucosal dissection, and in the area where we sort of had a suspicious nodule, we did a full thickness dissection. And this was a procedure that I still did during my time in Oxford, but nowadays I would actually choose a different type of plane. So, and these are the planes that I want to discuss. So if you have deep submucosal invasion, you have the option to do either full thickness or an intermuscular dissection. And I'll show you that intermuscular dissection, but also a technique which I use for all my dissection is first to put your diathermy dots at a safe margin. Then I tend to lift the lesion, particularly if you want to sort of separate planes. And then I start at the distal edge to open up the plane that you want to follow. And here it will be intermuscular, but if it would be full thickness, then I would be looking here for the full thickness plane. And once you've sort of found the plane that you want to be dissecting in, and you can see here, you can again see the nice white layers. And here is the circular layer. This is the longitudinal layer. It's a small polyp. It's from a trial that we're running in the Netherlands to compare this technique with ESD. And then you start undermining this lesion from left to right or right to left, doesn't really matter, but you leave the top bit attached, and only once you have it fully undermined, then you come across from the top to take this off. This is my general approach for each time that I perform local excisions. And here you can see, again, using the dye sort of to delineate the planes, and you can see here, these vessels that sort of transverse through these muscle layers can actually be quite significant, and I always control them separately. Here is a full thickness, and this was a very elderly patient that was already treated numerous times by gastroenterologists because she was not fit to have radical surgery, but only high-grade dysplasia, but also the 5th recurrence. So here we went then for a full thickness excision, again using the blue dye to delineate, then doing the markings, and after the markings, and really important to see here that it's really important that you try and put your markings also proximally, which sometimes means stretching more proximally to actually get access to the proximal extent of that lesion. and then again doing the same thing, opening up distally and then undermining. And for full thickness, it's really important that you realize that you don't have to take this fat. This fat sort of needs to be dissected off your specimen because you don't want to create a larger divot. By full thickness excisions, I tend to close the lesion. With the intermusculars, I don't tend to close anymore. But with the full thickness, usually a V-lock, and then from right side to left side, take a full thickness bite to close the lesions. There's not a lot of evidence to do this, but I think it tends to give less bleeding, and probably patients also can get to sort of tend to get less symptoms and pain once you close, if you close these. But for the intermusculars, I don't tend to do this. Now, full thickness or intermuscular, I think it depends a bit on the impact that that local excision is going to have on your potential need for completion surgery. So look at this polyp, it's only 2 centimeters, it's low, 2 centimeters from the puborectal sling, got a central depression, JNET type 3, so there's suspicion for deep submucosal invasion, and MRI, no suspicious lymph nodes. So here, what's the impact on your TME plane? Already shown by Colin, posterior, I would have no problems for this to be full thickness because there's the buffer of mesorectum. In the distal rectum, if you get a local recurrence there or an incomplete margin, that might mean an APE, even worse, anterior could be an exenteration. When can you still consider full thickness, in my opinion? Definitely not as a routine. When there's no impact on your TME plane and low risk for specimen fragmentation, i.e., for instance, posterior located mid-rectum, or when your local therapy is definitely going to be your definitive treatment and patients absolutely not fit for radical surgery or those refusing radical surgery. And you can see here, and you can imagine this is a full thickness excision of an elderly patient, rectovaginal septum. If you have to come back here to completion surgery, this is probably going to lead to specimen fragmentation. And if there's still tumor there left, that has a worse, sort of has a bad prognosis on your oncological outcome. Here also, a low-lying lesion, pull back, the port pull back into the anal canal. And here we're opening up onto the pelvic floor. So again, you can imagine here, if you have to come back for completion surgery, this probably will lead to specimen fragmentation. So here, in this case, I think the best option is to do intermuscular. And again, it's the same thing, sort of putting your diatomy dots, injecting, and once you've injecting, trying to find that intermuscular plane. As I previously shown in the previous video, you can see the longitudinal muscle still intact. Here, this was one of the first, so I was still closing those, but at the moment I'm not doing that anymore because the endoscopists are also not doing that. And this was a T2 cancer, small invasive cancer, 1.4 centimeters, no other risk factors. We considered this R0 because it was 0.1 of a millimeter, and we can discuss that. But what should we do with this patient? Okay, so T2, small tumor, no other risk factors, and I think this is a perfect introduction to urean stock, which sort of tells us what to do with the pathology if it comes back these type of features. So thank you very much.
Before we switch to urean, we have some questions for the participants again, because they raised the question, maybe not in all countries, the guidelines allow people to do local excision on a malignant tumor, which is proven malignant already. So Maite, can we put the first question for all the participants? So in your country, where you're at home, are there guidelines and are you allowed to do local excision of a known malignant lesion? So please vote now so we get an overview on the countries, if everybody is allowed to do that, what Roel showed. Okay, you see that at least in 1/3 of the countries, they think to be not allowed or have guidelines which do not cover that. And then there was another question rising up. So in some countries, the surgeons do flexible endoscopy and could do the same with a flexible endoscope. So maybe ask in which of your countries are you as surgeons also doing flexible and not only the rigid endoscopy or the TAMIS procedure, but if you're also doing a flexible endoscopy like colonoscopies yourself as a surgeon. That would also be interesting if we have countries here which do both rigid and flexible. So please vote. Okay, it's nearly half-half. So the same for me. I'm coming from Austria. I did it. Now I'm in Switzerland. I don't do it again. Okay, so thanks a lot. And we turn to Urian for the next step as Colin already opened and Roel proceeded. So we will have some answers from Urian now. What about the local excision and completion?
So thank you for again for the invitation. And after the beautiful overview of Colin, it was a great talk and very detailed, specific technical aspects of TAMIS by Roel. I will tell something about when or not to do completion surgery, or maybe an alternative. And I will play around with a case. So, of course, there's a need for rectal preserving therapy. Same for breast cancer. Rectal surgery is huge, and we're trying to do less invasive surgery, as Colin already mentioned. And now we have the modern techniques like ESD and TAMIS local excision. And yes, rectal cancer surgery, we're doing a great job with low recurrence rates, but we still are faced with a high morbidity. And it's just the big question is local excision safe? And that is a remaining discussion. And so in the Netherlands, we collected a cohort of 150 patients treated with TEM or TAMIS. And the unique thing about this cohort is that they had a full follow-up of 60 months with dedicated MRI and endoscopy. And in this cohort, we were shocked about the local recurrence rate of 22%, with the median time to local recurrence of 11 months. And these recurrences were not lymph nodes, but 85% was endoluminal recurrence. So if you do local excisions, you have to have a dedicated follow-up and tell your patients that they might need completion surgery, just like Roel said. And also, this local recurrence is not without consequences, because your overall survival lowers to 76% instead of 85%. So this is worrisome. So local excision can be safe, but you should know when. And there are various risk factors like depth of invasion. Size is also a risk factor. A T1 larger than 3 centimeters is a risk. Differentiation, lymphatic invasion, angioinvasion, the buttering, and the condition of the muscularis mucosae. And you should ask your pathologist, and if you're going to do TAMIS local excision, you should sit down with your pathologist and go through a standardizing of reporting pathology in early cancers. And the risk of, we know a lot about risk of lymph nodes, and lymphatic invasion and budding and differentiation are the main involved risk factors, and also submucosal invasion, which is deeper than 1 millimeter. And a recent paper, but this is in pedunculated T1s, showed again that these risk factors also apply for early colorectal carcinomas. So what should we do? So we looked at 3 different options what to do if you have a local excision for early rectal cancer. And if we split low-risk PT1s versus high-risk PT1s and even PT2s, and we look at the results of local excision, we see that in low-risk PT1s, there is still recurrence risk, but it's low, it's 6.7%. In the high-risk group, it's 14%, and PT2s are enormous, like 30%. But you can compare it with TME. What if you don't do local excision and do TME? Then you have 0% risk of recurrence. In high risk, it goes down to 4.1, and also in the PT2s, it goes down to 4.3. And this is completion TME, of course. So if you propose completion TME, you're lowering the risk not to 0, but to acceptable levels to 4%. So these numbers you can use in the outpatient clinic to discuss with your patient whether or not you should advise completion TME. You should always advise it in high risk PT1s, but again, it's patients tailored decision making, and sometimes you can opt for surveillance only. So let's talk about a case. This is a case, 50-year-old, a very distal lesion, and this is the diagnostic endoscopy. It's a rectal adenomatous lesion, and it looks suspicious, especially in the central stage. But the biopsy didn't show a cancer, but it showed high-grade dysplasia. Of course, we know that the pathology can be wrong and it still can be cancer. So we did an MRI, T2, and not 2.5 centimeters. So what should you do? And it is difficult because if you're not doing the endoscopy yourself, you should know more about this. Is it close to the sphincter? Is it anterior? Is it posterior? Because you have to think about how to dissect it, in which plane. And that is important. And realize that if the MRI shows it's a T2, it's probably T1, because we also looked at it at the accuracy of MRI in 3,000 patients, and in all the PT1s, 70% was staged as a T2. So there's a considerable overstaging. So the MRI can be used for lymph nodes, but not to distinguish T1 from T2. And then you should look at the MRI. Think about completion surgery. Where is it? Is it near the ARG? Is it near the prostate? And then we agree with Roel, you should consider doing a diagnostic local excision only. That means not going into full thickness, because that will harm the future potential TME. So what about if the lesion, which is next to this lesion, is a cancer and it's very distal to the ARG? I would consider diagnostic excision in our intramuscular plane, but not a full thickness excision. And what if it's posterior? And I think in posterior lesions, there's not much harm because you have the mesorectum, and then you can consider a full thickness excision. Because if the lesion is T1 or T1 with deep invasion, or even early T2, you can still consider rectal preserving therapy. And again, for anterior lesions, you should be aware that you do not want to end up in the abdomen, because then you have potential peritoneal spill, or in case of the prostate, you should probably be better off by intramuscular excision. So if you have early cancer and it's a suspicious cancer, consider local excision, both as a diagnostic but also as a therapeutic tool. You should always go for an MRI. Look if there are any lymph nodes, and look if the diameter is not larger than 3 centimeters. Because in the large lesions, you're highly likely to have a high-risk lesion. Consider your method of resection, ESD versus TAMIS. And if you do TAMIS, consider your way of doing a dissection. And keep always in mind completion surgery. This is what the different levels of dissection can be. And so in this case, we took the lesion out, and it was a T1 deep submucosal invading lesion with budding and lymphatic invasion. So does that mean it's true? Only if you have a very dedicated pathologist. If you consider local therapy, a second read by the pathologist. In our study, in the TSER trial, we looked at the quality of the pathology reporting, and in 30% there was discordance in risk analysis. So if you do a second read, there will be a 30% change in therapy, which is important. So if I was the patient, I would like my pathologist to have a second read. And then it's up for us and the patient to choose watchful waiting or completion TAMIS. But there seems to be another kit on the block which offers rectal preserving therapy, adjuvant chemoradiation. There's not much knowledge about it, but again, we looked at it, and it's not from randomized data, but it's from a small cohort series. If you for high risk lesions T1, if you do completion surgery, you take the risk down to 4%, and if you give them chemoradiation, it seems to lower the risk also to 4%. It's not the case for PT2. You can't lower the risk of a PT2 to 4%, and it's still 15%. But this data shows it might be an alternative to do local excision first, and then, if it's a high-risk lesion, add chemoradiation. But this is a lot of bias in these data. So that's why we have the TSER trial. And I would like to point out that if you do completion TAMIS, it might be a tricky business, because due to the inflammation of local excision, the TAMIS is more difficult. And we have shown that with TAMIS approach, and the next module, I think in 2 weeks, we'll talk about TAMIS, offers a huge advantage in patients that had a local excision first. So we analyzed, and this is a patient who had a local excision, and you can see the scarring. And she had a TT2, and the scarring makes it very difficult to do a TAMIS surgery from the abdominal side. And if you come from below, it's definitely much easier to get in the right plane, stay on the elevator, and then do the completion TAMIS surgery. We looked at it and we compared completion TAMIS with completion TAMIS. And the early data showed that the completion transanal TAMIS has less morbidity, less hospital stay, and most importantly, less perforations of the rectum, which are associated with recurrence. And also the quality of the specimen was substantially better. So if you do completion surgery, consider do that by transanal approach, but only if you're trained. And you're always welcome to join the TSER trial, where we randomize between completion surgery or chemoradiation. And chemoradiation is done with a small field radiotherapy with a tablet capecitabine, and it usually starts within 12 weeks. Thank you. This was my talk.
First, I want to give a question to all of you about the learning curves, maybe. So let's start with Colin. What do you think the learning curve for TAM and TAMIS? How many procedures do you need to make a proper local excision?
No, from literature it says it's about 20, but in real life I think it's a little bit more because you need the we know from single port surgery that it takes some time to learn the skills of working in a straight line. So I think it's more to 30 or 40 cases that you really are skilled in local excision transanally. But interested in the opinion of Roel or Jurjen.
Yeah, Roel?
I find it difficult to talk about my own learning curve because I already did TAM and then went to TAMIS, so probably that influenced it. But I would say that comparing the two, TAM is definitely more difficult than TAMIS because the instruments are much more difficult, the setup is much more difficult. And with TAM, you're sort of forced to work more parallel. The TAMIS platform allows you to do a little bit more laparoscopy. So I think 10-20 is probably a bit low. So I think realistically, starting from 0, I think Colin is probably right around 30-40. And then, of course, it comes the big difficulty is the learning curve probably now is longer than previously, because now in the majority of centers, you won't get a lesion anymore of 2 centimeters. They will be more difficult, they will be more distal because your gastroenterologists are getting better. So that's why it's important to have a good working relationship. Talk to them, try to convince them for you to get some easier lesions, because if you're only going to be doing difficult lesions, your learning curve is going to be quite long potentially. But I think 30-40 is probably right.
I agree with Roel that we made a deal with gastroenterologists that any polyp in the rectum is for us and anything above is for the gastroenterologist. Otherwise, we will never have enough the ability to do the local excision.
I would like to share that I think TAMIS indeed has a learning curve, and setting up the platform. You also need to invest in the insufflators and the platform. And it would, I would strongly advise to do next to TAMIS also other kinds of TAMIS procedures for benign disease. And if you are very experienced and you have a high volume, you can also embark on transanal TAMI. But the investment in your learning curve is helped by doing more with the technique.
This will also come next week when we're talking about transanal TME. So it's a kind of single port thing you do. So you have to be convenient with single port surgery, and you can do that on a box. So you can train to how to put your instruments. It was very nicely shown, I guess, in Roel's video, and also the picture, how to lift it up and which port you have to use for the instrument and which for the grasper. So this, I think, is very important. But I want to go back once to the learning curve, because as Roel showed, the full thickness and also the intermuscular, for a proper intermuscular dissection, do you think the learning curve is longer than for a full thickness, or will it be the same? Because your pictures look brilliant to see the planes, but especially in the beginning, I think this is quite difficult to stay in the right plane. Yeah,
I think full thickness, of course, easier. Absolutely. But the defects that you leave are much bigger too. And of course you have to be a bit more accurate, but by lifting it and then always doing the same thing by opening up distally, then finding the plane and then undermining. Yes, it's a little bit more fiddly because you have to sort of use an injection needle to inject the blue dye. But if you sort of know how to work TAMIS or work in a confined space, then it should be feasible. It is a bit more fiddly, but I think once you sort of know how to do TAMIS, doing proper intermuscular is probably not going to take you that long. Of course, if the lesions get bigger, then it becomes more trickier. But just doing everything full thickness because it's easier will harm the next step, I think.
Exactly. I totally agree. But now, from a perspective of the pathologist, wouldn't be the full thickness much better, especially if you want to know if it's a R0 or R1 resection, and also if this is an SM1, 2, or 3 for the T1 lesion, because this has an impact on lymph nodes and maybe the discussion with the patient?
But an intermuscular will always give you an R0 if it's T1, because you only take the circumferential muscle with you, so the one that you're leaving behind. So the only one where it couldn't give you an R0 if it's a deep T2. But even
or you change the plane. So if you are not able to do a perfect one, so maybe it's more dangerous that you step into the tumor.
Well, I think, of course, if it's really stuck and it's not lifting, this is also what sometimes the endoscopists do. If it's not lifting, then they go from a submucosal. They now also go intermuscular. So if that's not lifting, then you could always choose to go a plane deeper. But you should be able to stick with that plane. And that's again also what Phil Quirk says. We graded TME specimens, but he's now also looking at grading of local excision specimens. We should be able to stick to one plane. And he showed that talk at your conference, at the TME conference in St. Gallen, about quality assessment of the local excision specimens. I think we should be able to stick to one plane and not go for full thickness because our technique is not good enough.
Piecemeal, another topic. So the endoscopy is often to piecemeal, especially if it's more than 2 centimeters. So pathologists will not be able to tell us what we really want to know. It was on one slide that maybe piecemeal is an option if we think it's benign. How should we know it's benign? So you always go to not piecemeal, I guess.
I think that's the problem. You don't know if it's benign or malignant. But so I prefer to resect it in one piece, and that's the reason why we made a deal with the gastroenterologist to send it to us if it's getting too big.
Okay, so Colin, another question for you: the completion TME was only 29% in one of the studies you showed. So do you think this is typical for the study, or is this what we have to expect, that nearly 1/3 will not go for a completion TME after local excision?
I think that's what happens in the Netherlands currently. So these are results. This is I think that's not good, but this is the real life results. And I think a lot of surgeons do local excision and they don't follow on with the consequences that if it's bad pathology that they do a completion TME. But there's an oncologic risk in that. And maybe in elderly patients you can maybe justify it by not doing it, but in this study it wasn't just the elderly patients who didn't get the completion TME. I think it's also a wish of the patient, and maybe also advised by the local surgeons, saying, well, we do strict follow-up and we'll see what happens.
Okay. I think an important factor in that, Walter, because I think the study that Colin showed is a really important one. You have to make clear to your patients from the start that this is a big biopsy. If you tell your patient this is your treatment, and then they get the pathology back and it's R0, cancer's out, there is some risk, they're going to say, well, I don't want that big surgery anymore. They have to understand that this is potentially part of a larger treatment pathway. And if you tell them that upfront, then I think less patients will decline having completion surgery.
Thanks, Rory. I exactly wanted to point that out because it will be always a shared decision. We learned that especially in rectal cancer, it's shared decision. And this was already in the first questions when we asked the participants, it was clear that we have to do a shared decision with the patient. And this is exactly what I mean. It's the full pathology we will have with the local excision, and then we'll discuss what is necessary, and maybe it's the one or the other. So another question, what is the perfect timing after you have the local excision to do the completion TME? What do you recommend? What do you do yourself?
I wait for a couple of weeks at least that the wound is healed. And most of the times that's 4 to 6 weeks that I do the completion TME. It's also practical in scheduling the patient, but I'm not doing it too quickly.
I sort of follow the same schedule as Colin. I think if you speak to Matt Albert, but he works in a completely different system. If the pathology come back with adverse features, they sometimes go back within 24 hours, because then he says there's not a lot of inflammation. My opinion, you don't really have to rush, you know, you usually tend to go back for lymph nodes. So why not wait 6-8 weeks until that scar has nicely healed? And there's also less risk of specimen fragmenting, and then do a proper dissection at the time when everything has healed up. So I would also wait at least 6 weeks.
Any tips or tricks if you did a full thickness or you only did an intermuscular resection? Do you have another approach?
I think intermuscular is probably less risky for getting specimen fragmentation, but as Urian has showed, I think TATME is really quite helpful for completion surgery, because there you can approach the site where you did your local excision from both sides, and there's probably less traction on the specimen, less risk for fragmentation. So I think TATME for completion is probably a really good indication.
And saying you approach from both sides, you mean from abdominal and transanal? And I would also add, not starting at the resection site. So if you come from below, you start all around, and the last thing is, because there it will be scary, of course. So this will be the last thing you approach.
It allows you to do that last bit where the local excision has been done, to approach that as the last bit. And that's easier to do when you come from top and bottom.
Let's come back a little on the big picture. Colin, you mentioned the 5% local recurrence rate is acceptable, so we should be below. What we are sometimes missing is in which follow-up time is 5% acceptable. Does it mean 3 years, 5 years?
I'm not even sure if 5% is if the percentage is acceptable. This is what the guideline in the Netherlands states, that you're allowed to do that kind of dissection. And then if you recalculate, then apparently 5% is what is acceptable. But maybe more is acceptable, we don't know. We know now from the watch and wait that we don't really damage the prognosis of the patient if we wait a little longer, and if the recurrences are treated at a timely basis. I always explain it to my patient that you have to, oh, urine is back.
Open die dus niet eerder diagnosticeren voor het detecteren van peritoneale metastase.
Urian, put your microphone on.
Oh, sorry.
Okay. This is I always explain to my patients. I don't think that the patient's oncology is really damaged if you have a local recurrence after a local excision, but your function is. Because what will happen is that if you have a local recurrence after a local excision, the majority of the patients get radiation therapy extra before you have the completion, the TME, not the completion TME, but the TME. So I'm not sure what the percentage of 5% is really the endpoint for as acceptable.
But in your guidelines, what is it? 3 years? 2 years, 5 years? What is the 5%?
Not even sure.
1 year?
I'm not sure. I think it's
not sure.
3 or 5. I'm not sure.
Royal, what do you think?
I think these results are usually short term. All the studies have the short term results. But yeah, I think what is acceptable, patients are willing to accept quite a lot sometimes to prevent a large operation. There's some nice modeling being done. They're willing to give up 17% of life expectancy to avoid a large operation. So yeah, I think it's all about shared decision making, but also we're getting now more insight of what the risk is. For instance, depth of invasion as a single risk factor is, if you look at that Bach model, quite significant. But when you now look through the literature, depth of invasion as a single risk factor is not that significant. It's actually lymphovascular invasion, tumor budding. Okay, if you have depth in combination with lymphovascular invasion, for instance, then the risk goes up. But depth of invasion as a sole risk factor, there's only 1 to 3% risk of lymph node recurrence. But as Urian showed, sometimes it's more luminal. So do we need to improve our technique? and avoid tumor soiling in a large bed, a resection bed. All those things matter.
As I see that,
sorry,
Colin.
Do you think that the prognosis of the patient is compromised if you have a local recurrence after a local excision? Because from the watch and wait, then if there is a recurrence, then the prognosis isn't really compromised. So personally, I think we can accept a higher local recurrence rate as long as we do strict surveillance, and we can treat the patient at the proper moment. Only it will influence the impact of your function, because when you have a local recurrence, most of the times you have a neoadjuvant therapy which will influence your function. So that's the big impact. Do you have the operation at the beginning, or someone say, do you wait and have the risk of of an operation later on with a poor function?
I agree with you.
Yes, I can. Can I add that the literature is not very sound because it's all poor quality, but the cohort we have that says that the local recurrence is not without consequences.
Okay.
And so I think you should be honest to your patients, and some patients do choose for rectal preserving therapies and choose for watchful waiting, but there is a risk. And it's not that all the local recurrences can be treated.
The results from Bates in the watch and wait, it says it doesn't influence your prognosis, as far as I know.
Yeah.
You have the different group of patients, I know, but it is a local recurrence, and it's the same.
Actually, there was also a paper from Dieter Hanlos who compared those two groups who had a local excision, and the one had salvage and the others had not. And those who had not salvage, they came back as a T3 or T4 when they were recurrent. So this would have an impact.
That's the question. Follow on.
But that is indeed all very old data from a US practice where patients after the local excisions go back to the local hospital, didn't get proper follow-up, and then came back indeed with large tumors, and they even had to have a major surgery. I think the data that the graph has shown is that if you follow the knot well, the majority you can salvage by standard TME surgery. But even that small study from the graph did show that if you do completion surgery or salvage surgery then for recurrence, there is an impact on survival. So there is some data there that if you have a recurrence, that it does impact on your oncological outcome.
Okay, there was another question for you, Rian. So you showed also the radiochemotherapy and local excision. So what is the timing between those two?
So chemoradiation is best done within 3 months after local excision. Not immediately, because then you still have sepsis locally. But you can delay it. And then in our series, it's well accepted by the patient. There is a degree of radiation toxicity like diarrhea, incontinence, but usually that is that dissolves. But then again, the data there is on chemoradiation is very small. It's not audited data, so I think it should be offered within a trial so we can collect the data, so future patients can benefit.
What about the other way around, doing the radiotherapy before and then the local excision?
Oh, yeah, that is a strategy which is, I think, being studied in the Star Trek. And the problem is that you don't know what you're radiating. You don't know if it's a T1 or T2. It might be a T1 which you can treat with local excision only. And we know cases that you add chemoradiation and the local excision is done with much more morbidity, because the local excision after chemoradiation is more difficult and adds more morbidity to the patient. So I think it is feasible, and if the chemoradiation gives a small residual lesion, you should talk to your patient that you can offer it, but it has association with more morbidity. And I'm against chemoradiation for small lesions that you could have done by local excision only.
So Haber-Gamma's data show the opposite. So this is what they did, and they was first doing the local excision, and then they're only doing the watch and wait after the radiation. So in your country, I think is anyone going for that?
I think what Haber-Gamma
in the Star Trek.
Yeah, they did. In Netherlands, are doing it in the Star Trek. Of course, we had the French Greca study, and what I know from Rodrigo Perez is that they're moving away from local excision as much as possible, because I have patients that one or two of them convince me sometimes to do this, and you can pick them out of the waiting room for the next 6 weeks. They're not sitting down, they're incredibly uncomfortable, and it's really painful. And sometimes you think, oh God, I have to bring out the stoma because he's in so much pain. Usually they get over it without a stoma, but you have to prepare them for a really horrid time. But it is a standard in France, where there's a small residual tumor left, and if it's then less than a YPT2, so if it's a YPT1, then those patients will have further surveillance, because in their study the risk of lymph node disease in those patients that had YPT1 was very low, but I think it's very morbid, so I don't tend to offer it unless they really push for it.
Okay, I think that was a brilliant discussion already, and as I see, Alois first is also one of the participants. We have, of course, to point out one of the most important trials was the COLOR2 trial, and coming back to the local recurrence rate, maybe that's the line we at least should pick up and say what is therein after 3 years, after 5 years local recurrence rate. We should be lower and lower, so there should be a progress, and maybe then we have below 5% after 3 years. That would be an edge we should really cut. Now we have some questions for the participants prepared. Some last ones to ask you after these lectures, if you're considering something. So Maite, maybe you can take the 2 questions. The one is for you: are you doing TAM or TAMIS already now in your hospital? So if you can please vote, that we know in the end who is doing already TAM or TAMIS in his hospital. That's the first one. Let's have a look. Please vote. And then, okay, so it's one third around is not doing it, and 2/3 are already doing it. And the other question is for those who are not doing it after these lectures, please. So now only vote those who had voted with no. If you are considering to introduce the technique in your hospital, only those who are not doing it up to now. The others, please don't vote, otherwise it makes no sense if you're doing it. So are you considering yes, maybe, or not at all? Okay, so maybe we were able to convince some of you that this could be a good technique. If you're going to introduce this, please be sure to have a good workshop, have a proctoring, count a little bit how many cases you will have in your hospital, if it makes sense to do it alone or to do it together with others, and talk to your gastroenterologists. And in the end, of course, I want to thank, even if Jurian already went out again, unfortunately, I really thank the distinguished panel, and it was orange all over in the Netherlands. It was a great Dutch group. Thank you very much for being here. And I want to thank also Medtronic for organizing this. Maite and all the others in the background you are not seeing. It is a perfect webinar series. Thank you very much. Have a nice evening.